It's quite early. It's also very happy to have the opportunity to come to here to share some of the experience. We all know that the Thermo Operation Society actually was based on the foundation of the treatment for hepatoma. And thyroid has become more and more cases in the past 5 years. And so we are thinking about that always there is something good and something bad that happen in the hepatoma treatment. So the most important thing is that we not just only to set up the Thermo Operation in thyroid, but is there anything that we can really learn from the hepatoma and especially our senior member from ACTA. So that's I got an idea that I try to figure out what currently development in hepatoma previously, now and future, and maybe something we can really learn in the management of the thyroid. So I would like to touch some part of the history of and the future trend of this both disease, and majorly focus on the local treatment, ablation, embolization, and radiation. And also I like to include some recent advance and emerging therapy strategy and try to figure out any innovative treatment approach and compare their outcome. So basically the two diseases pathological is quite different. So I think the clinical decision will highly depends on the disease biology. For example, indolent in thyroid, but very aggressive malignancy in hepatoma. So the disease of biology and the characteristic might affect the treatment strategy, selection, and prognosis. So for hepatoma, so far surgery is the first line for resectable tumor and widely being used in ablation. And for the embolization, especially the intermediate stage, is the standard treatment. But now more and more tachytherapy, such as solafalimab, lenactinib, will be included in the take care of the advanced cancer, and not to say the immunodevelopment therapy in the current status. And how about thyroid? Thyroid, the standard treatment, still very, very dominant. I think maybe more than 95% of the cases were treated by surgical resection, and only using ablation for very, very low risk of microcancer, and only in few cases in the world. And embolization is experimental for large goiter or some uncurable metastasis nodule. But interesting is that for tachytherapy and some immunotherapy in the thyroid cancer, it is a little bit better development compared to hepatoma. So first, I would like to go through the timeline of the development of HCC. HCC had the first reception in 1950, and after that, introduced of the embolization to management of the cancer. And since that is early 20th century, the development of laparoscope, IVA, microwave, and also drug-enabled embolization into the management of cancer. And since 2010, there are a lot of tachytherapy introduced in the management of advanced cancer, and now also incorporate immunotherapy. So especially for the combination therapy, it began in 2005. TAE and IVA first is a local regional treatment, and then introduced together with tachytherapy and immunotherapy. And how about the thyroid cancer? You see that like a very, very big white area since at least before 20th century. The first thyroidectomy is been done in last century in 1850. But after that, surgical resection, all kinds of surgical resection, it developed, try to maybe alleviate the wound or the complications, something like that. Just until 2000, they have come with the Thermo Operation for the benign lesion, and in 5 years earlier, start with some tachytherapy and immunotherapy. So it is a lot of big delay in the management of thyroid cancer. And then talking about the combination therapy, surgical resection majority with radiation therapy. But since 2010, they are TA with IVA, TA with IVA, with target therapy, etc. So the development is become faster and faster. But compared to the hepatoma, that one management that's quite different compared to HCC is the active surveillance. There's no active surveillance in HCC. This idea is been raised and been conducted in Japan Kuma Hospital. And after this active surveillance, we found that low-risk cancer is quite indolent. And even you delay surgery, the complication rate is similar to the immediate surgical one. So thinking about that, active surveillance now have been applied in a lot of different countries like this. And this figure yesterday, Dr. Kim also mentioned this figure. We can separate cancer, depends on the location, and include them or exclude them into the active surveillance program. So if the cancer is looked with a wide angle to the trachea or the thyroid bed, I think it may be a good candidate for active surveillance. And how about the major treatment concept for hepatoma? Majority, we would try to cure the cancer. You can apply the ablation, TA, and resection. But if once the patient cannot go for curative therapy, the major purpose of us is try to make it downstaging. That allow us to do ablation or even a waiting list enough for the liver transplantation. So the first I would like to touch is the tumor ablation, including chemical, IVA, microwave, cryo, IRE, and HIFU. In liver and thyroid, majority is using IVA and microwave. For hepatoma, now lesser than 3 centimeters is curated. But for thyroid, it's just only for functional preservation, and it's an emerging strategy for selective application. For example, no lymph node should be detected initially. But compared to thyroid management using thermal ablation, there are a little bit higher complication noted in hepatoma. So it depends on the location, different complication might occur. But luckily, we have hydrodissection. For example, in liver, we do hydrodissection to separate, become a water barrier to protect the bowel. And in the thyroid, we also learn from that. We do hydrodissection to have a better ablation result. Majority is there are 4 different modalities. For IVA and microwave may be very similar in two cancer. Cryo and only applied in HCC, and laser therapy only applied in thyroid. Some author, physician would always ask this kind of question that which one would be better between IVA and microwave? We need to say that microwave indeed have more powerful than IVA, and so far for liver disease, the same or thyroid goiter, we prefer using the microwave in large volume with a faster heating. But I think the technique choice depends on the tumor characteristic, for example, the size, location, and the equipment available. And also the most important is the experience of the physician. And now we also get a lot of idea from a lot of conference. And also our president, Dr. Huang, introduced the IRE and histotripsy several times. For IRE, that is the mechanism using electropulse to create a permanent nanoscale pore. So by using this method, it can very selective target to cellular component and leave the extracellular matrix completely intact. So especially in thyroid, there are a lot of critical structures such as a nerve vessel that we need to protect without damaging. So this kind of new mechanism, thermal ablation modality definitely might help us to manage more difficult cases of the thyroid. And so far, it has been applied in liver disease, but not yet in the thyroid disease. But within that, so far in the rat model, it can protect the trachea from with damage and can also the adjacent structure. The other one is the histotripsy. It can create a bubble, then give some energy to collect the bubble within hundreds of microseconds, and also rapid expansion. By using this mechanical strength, we can disrupt the cellular structure. And one advantage is similar. It can prevent the collagen structure, so it has no harm to vessel, to the duct, and also to the nerve. And how about currently situation? It has been applied in liver, but not yet been done in the thyroid. And only an animal model were found by using histotripsy in the United States. So we can take advantage of the histotripsy with a no neurovascular injury in thyroid management. And then I would like to touch a little bit about the PTMC. PTMC so far, the 5-year, even 10-year result is very, very good. It can reach 95%. And majority there are no report of death due to because of this procedure. But anyway, it has some inclusion criteria. I would not like to go through that. But you can see these cases is a PTMC very close to the isthmus of death, and after ablation, 1 year later, it completely disappeared. And luckily, in this year is a very, very good year because we have a lot of evidence support us to continue working in this direction. We have consensus published in radiology. We have 10-year results from Korea team. And most luckily, in the past 2 months, we got a new ATA guideline in a new version since 2015. So I just make a joke. Everyone relax. I put this movie for you.
We have a long story about thermal ablation for small thyroid cancer. When we had the 6-month results,
you people are committing a crime against patients. This is evil. Stop IT right now.
When we had the 12-month results.
Oh, you poor souls. Ablation can't kill cancer. And reoperation? Practically impossible.
When we had the 24-month results.
There's a silent army of metastatic lymph nodes out there, hiding, waiting. Just wait and see.
When we had the 5-year results.
Oh, in my 20 years of clinical practice, I have seen cancers metastasize, even 10 years later.
When we had the 10-year results.
All your data? Just regional.
Let's see what ATA has to say.
And then, ATA 2025 came.
It says, ultrasound-guided percutaneous ablation may be considered as an alternative to active surveillance or resection for CT using memory PTC in selected patients. Shared clinical decision-making between the patient and clinical team regarding the risks and benefits of this approach is essential.
We need to say that we really appreciate Dr. Bae and the team of Korea do a lot of investigation in this field. And now we come to the golden time in thermal ablation to treat the thyroid cancer. And now we know we can use thermal ablation to treat small cancer. And how about the big one? This girl or this woman is a dementia, and patient will not like her to accept a thyroidectomy. That's the sonography. You can see a very huge bulky tumor in right thyroid, conversion the trachea, narrow the trachea. So we're thinking about a policy that has been done in HCC. We use NTA to downstage this cancer. You can see over here, decrease the size of the tumor in right. And then we apply the IFA for the cancer again. So let's just see the 3 time point PET study from a very huge body mass activity with a shrinkage and violation, and even smaller after the thermal ablation 3 months later. So that's a good idea that we use in this combination therapy to management those advanced unresectable cancer thyroid in the future. So downstage for HCC have been proved in many cases and can to reduce the comorbidity. And the advantage of the combination therapy is to reserve the liver function and the potential combined with the systemic therapy to improve the prognosis. So in the following, I would like to introduce emulation. the embolization in HCC and thyroid cancer. In summary, in short, that so far all the application embolization in HCC is better than thyroid, no matter their treatment role, the curative evidence, and quite frequently being used and already integrated into our daily practice. And from the thyroid, TAE as HCC embolization, majority the bridging to transplantation, downstaging, all become a palliative treatment. You can use, for example, you can use a simple embolization because ischemia necrosis. We can use the chemotherapy to increase the toxicity of the cancer, or we combine both of them with immediate ischemia and sustained drug release to kill the cancer. And also by using the Yttrium-19, the radiation we create a lot of free radical leading to DNA damage and the tumor necrosis. So I show you the result in my hospital that after Yttrium-19 successfully to downstage, 70% of the patient can have the opportunity to go for liver transplantation. And compared with those with Yttrium-19 downstaging or not, you can see the patient have more opportunity for liver resection, transplantation, and have a better long-term outcome compared to those without. So how about the embolization of the thyroid cancer? Majority the first indication is palliative. It can use for life-threatening hemorrhage to serve trachea compression with dyspnea, painful, or some active bleeding tumor. So it just reserved for highly selected cases. And the second indication is a pre-operation embolization, for example, for anasphatic thyroid cancer, poor differentiated thyroid cancer, because the high vascularity may make a lot of trouble during the operation. So let's look at the embolization currently applied in the big goiter. When we facing the big goiter, something we carry some trouble. For example, the anatomy distortion may lead to the difficulty of thermal ablation. Under ultrasound, everything becomes disorientated, and at the same time, once the tumor very big, the vascularity definitely very prominent, so lead to a lot of complication. But by using embolization, it is a needle-free, ultrasound-free, and also can decrease the vascularity at the same time. So looking at our paper published in Radiology, we found that even the same size of the goiter compared to thermal ablation, TAE have a better volume reduction after follow-up, especially when the tumor is extremely big, for example, more than 100 cc, the result is even better. So the advantage of embolization is that it can hit this patient, and it can management the intrathoracic extension mass, and we don't need to take care of the safety margin or even the calcification that could be found in the goiter. And once already block the supply of the tumor, the regrowth potential would be eliminated. But there's still some issue need to be solved. For example, the anatomy of the vessel, because once it becomes a cancer, a lot of neoplastic vascularity will go into the cancer. So what type of vessel, how many vessels we can embolize is a question. The second one, we need pre-procedure planning to find out the target vessel. And the most important is compared to liver disease, we have no idea which kind of particle would have best benefit to the thyroid cancer yet. So far there's no randomized control trial for the thyroid cancer management. And the quick question is that we have no long-term survival data. And where does this technique fit in our evidence-based treatment paradigm? It still needs time to solve. In the last part, I would like to mention the radiation therapy potential cancer. Similarly, both cancer apply radiation for the unresectable cancer, or the macrovascular invasion, or the TAC, TARE is unsuitable or refractory. And so the current development for radiation is combination with such as a TAE, tachytherapy, and immunotherapy. But interesting is that once introduced of the particle therapy so far, they have a lot of improvement of the external radiation in the management, especially the macrovascular invasion, HCC. You can see the result, 1 year survival is better than the conventional management. And how about the thyroid cancer? It is similar for unresectable local regional disease, symptomatic metastasis, adjuvant therapy, or the prevention. But you need to know that for this kind of conventional radiation, a lot of neck actually should be covered to prevent the new growth of the cancer. And most evidence just are based on the case report and the case series. So compared to those without adjuvant external radiation, radiation can improve the local control of the thyroid cancer. And together with surgery and irradiation therapy, combination with external radiation also can control the high-risk differentiated cancer. But so far, the 5-year local regional recurrent-free survival, it seems in some cases, but not overall survival or distant metastasis study for the external radiation. So for HCC, so far it's quite confident that we use external radiation to do downstaging the macromuscular invasion cancer with a very excellent local control rate, and can already be demonstrated to increase the survival benefit and have been established in a lot of multiple model care. But for advanced cancer, currently it's just experience accumulating phases and do not have a good research touch this part. But we try to using external radiation to help some of our patients. That's the cases we combine thermal ablation and external radiation to those very difficult cases, especially for cancer located in the tracheoesophageal group. And so far, for 11 cases with unresectable recurrent thyroid cancer, the 2-year follow-up is 100%. It means no tumor recurrent in this area. So it is quite exciting to know this idea, because by using this combination therapy, we can reduce the radiation field. Of course, we can improve the quality of life and reduce the side effect. In the last part, I would like to touch the advanced cancer with common trend in HCC and thyroid. Both cancer employ multiple model treatment approach, and targeted therapy is become a very important player in management of these two diseases. And to management these two cancers, we are looking for the precision medicine, and also the molecular testing is increasing use. And of course, we don't need a very strong Superman. We need a very good team. It means that we need a multiple discipline team for the decision making. So the treatment decision process is for the targeted therapy is applied for rapid progression disease, symptomatic tumor in a threatened location, or fail the local treatment. For hepatoma, molecular marker assessment is increasingly important, but fewer clear druggable mutation was being used, but the gene expression profile can predict a treatment response. But more luckily for HCC, we now using comprehensive NGS testing become routine before we apply the systemic therapy, especially for cancer have BRAF, RAD mutation, or NTRK mutation. Both cancer had applied the first-line VEGFR targeted therapy for lecanemab, sorafenib, and cabazantinib. So this is the trial compared with placebo in the thyroid cancer. This is the sorafenib, lecanemab, and this is the result of the cabazantinib. Have obvious advantage, but majority all of the disease just can improve the progression-free survival between 1 year to 2 years. So now we are searching for the combination therapy for HCC. We combine TA-IFA and targeted therapy, or we can combine both of them at the same time. And for thyroid cancer, surgical resection first, IAI next, and targeted therapy. But now more and more evidence, especially last month I just come back from ATA, now more and more topic touched in the neoadjuvant and then surgical resection. So in the future, the role of immunotherapy, optimize the combination therapy is very important, and we should try to find out and overcome the resistant mechanism and try to standardize the neoadjuvant therapy. For example, this is a case of H19 and combined with immunotherapy. First, we are using String-19 to do embolization. We think it's a tumor, but there's still a bulky mass in right liver. And follow with immunotherapy, complete necrosis of the tumor. And in our center, we also do combination therapy. We compare the target alone and the combination therapy, including the reoperation, external radiation, IFA, and embolization. And you can find that compared to target therapy alone, combined therapy with other local regional treatment have a better long-term outcome. You can see the progression-free survival time is almost double than the monotherapy target therapy. So this one cases apply IFA to treat the tumor invasion to the trachea and larynx. So I would like to summarize. Now there are more and more weapons allow us to do combination therapy. Hepatoma provide a very good blueprint for thyroid cancer management, especially in the integration of the local and systemic therapy. And very interesting is that the new release guideline ATA talking about to that, if the tumor is less than 2 centimeters, or even is between 2 to 4 centimeters, within one lobe only, single lobectomy is allowed if there are no lymph node metastasis. It also suggests to try to avoid any prophylactic central lymph node dissection, only consider for advanced cancer. So we are thinking about that. So indolent of the PTC, we have an active surveillance guide program to the PTMC ablation, now even move to the T1B and even T2. So maybe in the future, thermal ablation is good enough. Maybe we will do the same thing, very similar to lobectomy for those without clinical lymph node metastasis. And we need to introduce and emerging some new techniques such as IRE and histotricity because they have no hissing effect and can very selective to target to the tumor. And the most important, it can preserve the normal structure such as the nerve and vessel. And for the embolization, it's well established in hepatoma, but it's a long way to go in the thyroid cancer. But we believe TAE should show very promising for thyroid application, but need a very good prospective study to establish its role in clinical practice. And for combination therapy, it is a synergic mechanism. Now, not just only liver, but also other tumor can apply. We use a local therapy to reduce the tumor burden first. Then we combine systemic therapy to control the micrometastasis and also the residual tumor. And by using this method, maybe we can enhance the immune response through the so-called abscopal effect. I think that I hope I do a good job for this review. Anyway, ACTA is a very good society. We learn and support with each other and move forward together in ACTA. Thank you.
Thank you, Professor for a very interesting talk. It was fascinating to see such an overall perspective